I will next demonstrate the axillary exam to look for lymph nodes. And for purposes of this exam, I had Steve lower his gown so you can easily see what it is that I'm doing as I'm checking. I'll come over to this side here, and I'll bring Steve's arm up, and I'll support his arm to allow relaxation of the musculature. And I'll take my right hand, and I'll palpate along the inside of the axilla, coming up this way first, and then checking along the chest wall here. Then check along the posterior musculature just on the back side of the axilla, and then along the anterior musculature here as well. So I've checked in this area, through here, through this area, and also through there. If you have a female patient and you don't remove the gown, that's all right. You can either allow your arm or your hand to go in under the sleeve here, or from the back of the gown and checking in the axillary region. Now I would do the same thing on the other side. Again, lifting the patient's arm and either using the same hand or the other to again check in the axillary region. All right. Now I'll move to the posterior thorax exam. Now Nick, could you untie your gown and move it off to the side of your back a little bit? For purposes of this video, I have Nick sitting on the table sideways. As you're typically examining patients, your patient will be sitting forward on the table and you will move around the patient as need be. Now the first part of the posterior exam is inspection. Looking at the back, checking for moles, checking the integrity of the spine, how the spine lines up in the middle. Now Nick, can you take in a big breath and let it out? Watching to see that the chest expands and contracts normally on both sides. Then I'll also palpate as he is doing that. Nick, can you take another deep breath and let it out? All right, that would be part of the palpation of the thorax to make sure the lungs expand and contract equally. Now the next part will be to palpate the spine. I'll start at the very top of the spine, palpating along the spinous processes, and tell me if there's any pain or tenderness as I'm palpating here. Applying fairly firm pressure, enough so that I can see the whites of my fingers beneath my fingernails. Then I'll do the same thing along the muscles on either side of the spine as well, checking again for any tenderness, any masses, or any other abnormalities. And I'll go all the way down along the spine as well, following the edges into the lumbar area. This is followed by percussion. And with percussion, you would percuss in at least 4 different areas on the back, following a ladder-like fashion, moving from one side and then across to the other, percussing here and then here. And in a second area here, a third area here, and then a fourth area here along the sides. Now in a female patient, you have to make sure to cover the area of the chest underneath the axilla from the back, because you'll not be able to easily uncover that in the anterior chest. Now Nick, can you cross your arms across your chest here in front like this? All right, what that does is that brings the scapulae out to the sides a little bit and allows you to percuss in these areas just slightly easier. The next part of the exam is auscultation of the lungs. And again, I'll follow the same pattern with auscultation that I did with percussion. I'll ask the patient to take nice deep breaths with his mouth open. And I'll listen to a full inhalation and exhalation at each of these locations. So first, second area, third area, and again under the axillae. All right, you can relax your arms and you can move your gown to the back again. Now I won't ask the patient to tie his gown at this point because I'll be moving to the anterior thorax exam. All right, Nick, if you could turn around so that you're facing towards the camera. Now I'll proceed with the anterior thorax exam. Nick, could you lower your gown so that it's sitting just at your waist here? Okay. In a female patient, I would ask her to lower her gown and hold this up over her breast. But in a male patient, it's perfectly acceptable to let the gown sit at the waist. And I have the patient here looking towards the camera for purposes of this video. Normally, I would not have the patient move. I'd have the patient sitting forward with his feet resting on the stool. Now I'll start again with inspection of the anterior chest here, looking again at the skin for any moles, any asymmetry from one side of the chest to the other as well. I'll also then move into percussion, and I'll percuss at least 4 areas on each side of the chest, again following a ladder-like pattern. Upper part of the chest, middle part of the chest, and lower part of the chest here as well. In a female patient who's holding her gown over her breast, I would percuss in about these 3 areas on this side, again following the ladder-like distribution across in those areas above her breast as she's holding the gown just above her breast. And then I'll follow this with auscultation. Again, listening in 3 areas of the chest. Taking a deep breath here, in and out with your mouth open. And again, continue that. And a 3rd area here. Okay, thank you. Now you can replace your gown up over yourself there. And that ends the anterior thorax exam. Now I'm going to move on to the cardiovascular exam. I'll start first with palpating the carotid arteries. Carotid arteries are best felt just laterally or just on the outside of the trachea. First I'll check the right side. I'll let my hand sit there for just a few pulse beats, make sure I feel the pulse. Then I'll move over to the left side, just on the outside of the trachea again, palpating. Notice I'm using several fingers to find the pulse. Notice also that I'm checking one side and then the other. If Mary had arteriosclerosis or some thickening of the wall of the arteries, and if I press both sides at the same time, I may compromise the blood supply to her brain. So I'll check one side, then the other. As I look at the neck, I see the sternocleidomastoid muscles here on either side and the trachea in the middle. And the carotid pulse is usually found right between those 2 landmarks. Now, after I find and palpate the carotid pulse, then I'll take a listen. And listening to the carotid pulse and all the other pulses for bruits is best accomplished with use of the bell. So what I'll do is I'll place the bell in the same place that I palpated the carotid artery and ask Mary, can you hold your breath? I'll hold my breath at the same time. I'll listen for a few heartbeats. I'm listening for whooshing sounds that would indicate carotid bruits. You can breathe again. And then I'll listen on the left side again. Hold your breath again. All right, and breathe again. Over the carotid arteries, you can sometimes hear the sounds of S1 and S2, the heart sounds, but you shouldn't hear any extra sounds in between that. So that concludes looking at the carotid arteries. Now I'll move on to the chest. Mary, could you lower your gown a little bit further? The first part of the examination of the heart is to inspect the precordium. That means that I'll just take a look at the chest, watch the chest rise and fall, look for any extra pulse beats that would indicate an enlargement of part of the heart. And I also can notice my landmarks here. Here's clavicle here on the right and clavicle on the left. As I move to the center, there's a sternal notch at the very top of the sternum. And I move down, there's the sternal angle. The sternal angle is going to help us to locate the second intercostal space. So I find the sternal angle here. And then as I move just laterally across from the sternal angle to the right side, I'll locate the second intercostal space. This is where I'll listen to the aortic valve, and that is located between the second and the third rib, the second intercostal space here on this side. And located just on the left side of the sternal angle also is the left second intercostal space where I will listen to the pulmonic valve. Now, what I'm going to do next, and for purposes of demonstration, Mary's head is a little higher than what we would typically have it. We want the bed to be at about a 30-degree angle, but so the camera can better see what we're doing, we have Mary at a 45-degree angle. All right, so I've looked at the chest, I've inspected the precordium. Next, I'm going to palpate the PMI. So Mary, would you be able to raise your gown there? And I'll hold the sheet while Mary pulls the gown up. Yep, there we go. All right. And if you could pull your gown up just under your breast there. Now, the point of maximum impulse is located right in the midclavicular line at about the 5th intercostal space here. So what I'm going to do to palpate the PMI is place my whole hand just beneath her left breast, and I'm going to find a pulse there. When I find that with my hand, then I'll localize in just with my fingertips. With my fingertips, I want to find where is it exactly located and what is its size. And so as I'm pressing here, I'm feeling the pulse right underneath, which is the point of maximum impulse. All right, now I'm going to listen to some heart valves, so you can lower your gown again and bring the upper part down just a little bit further if you could.
Okay.
Same thing, yep. So Mary has moved her gown so that it's just above her breast so that I can start to listen to heart valves. I'll first listen to the aortic valve in the right second intercostal space, allowing several heartbeats to pass, listening to the quality of S1 and S2, and for any murmurs in between S1 and S2. Then I'll move over to the left second intercostal space. This is where I'll listen to the pulmonic valve. Then the tricuspid valve is located several intercostal spaces lower in about the 4th intercostal space. Again, I'll listen for several heartbeats and make sure I don't hear any differences in sounds or any sounds between the valve sounds. And then, now Mary, you can raise your gown again and bring it up from below. The mitral valve is located in the 5th intercostal space, right at the midclavicular line. Same place that you find the PMI typically. So I'll listen there also with my my diaphragm of my stethoscope. And again, listening to S1 and S2. Now, located at the apex of the heart is where you may hear some low-pitched heart murmurs and low-pitched heart sounds that we'll work with during PDS3. These low-pitched heart sounds are best heard with the bell, very similarly to the way we heard carotid bruits. So in the apex, you'll also listen not only with the diaphragm, but also with the bell of the stethoscope. Now, to use the bell correctly, you just very gently set it on the chest wall. And you're listening again for any low-pitched heart sounds. And that concludes the cardiovascular exam.